Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect the official policy or position of any entity aside from possibly Cash Like Moore Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders, and Paul, I'm going to get all the way through this tonight. Stuart had somewhere else to be tonight, but I am joined by the great Dr. Paul Williams.
Hi, Matt. How are you?
I'm doing well, Paul. You sound surprised
Great.
that I'm talking to you.
Yeah, I'm not used to being directly addressed. I was someplace else.
And with us tonight is Dr. Carolyn Chan. Carolyn, thank you so much for joining us.
Yeah, hey everybody. Excited to be here tonight.
And this is what, your second or third show you've done with us now?
Yeah, I think this is my third show, I think second time being on an episode. But we have like a great show tonight. I'm so excited today because we get to talk all about the new C. diff guidelines. And I think that this is probably going to be the most exciting talk you've ever heard about C. diff. It's going to like blow your mind. We're going to talk about treatment, how we do different laboratory methods to test for it, and some really cool up-and-coming stuff with research regarding fecal transplants. You'll learn today how many pills you'll actually need to take to have a fecal transplant, and a bunch of other cool facts.
With the great Dr. Curtis Donskey. He is a professor at Case Western Reserve University School of Medicine. Dr. Donskey's expertise and research focus includes the epidemiology and transmission of C. difficile infections in the elderly and in nursing home populations, as well as the infection control issues of antibiotic use. He serves as the chairman of the Infection Control Committee at the Louis Stokes VA Medical Center. So without further delay, here is our discussion with Dr. Curtis Donskey. All right. Well, Curtis, thank you so much for joining us tonight on the show. This is a topic that we get a lot of questions about, and we do have a lot of questions from social media. So thank you so much for joining us.
Happy to be here.
This is tradition on the show. Before we get into the main topic, we always ask kind of a couple questions up front. And then the first one is always, can you give us a one-liner about yourself so the audience can get kind of a flavor of who you are?
I'm a 55-year-old infectious disease physician. We're not doing ID research. I like spending time with my family and hiking and biking.
Curtis, what book do you feel like every physician should read? And if you don't have a specific answer for that, then if you could just give me a book recommendation, that would be great too.
A book that I recommend is called Being Mortal by Atul Gawande. A very, very good book.
It's a great book and a popular answer.
I haven't actually read that one. What is the... Curtis, can you give like an example of what a story from that book or why you think it's so valuable?
Well, he talks about how his father died and how that was different than the way, people often die in hospitals today, where it's a kind of a long, drawn-out process instead of more of a natural process.
Carolyn, did you want to ask a question?
Yeah. So what is the best advice that you've ever received as a learner or as a teacher? Anything you'd like to tell a house staff?
I've received a lot of advice that I haven't necessarily followed very well, but one piece of advice that I've often heard is that you should focus on one area you should be focused. You should not be kind of diffusely looking at a lot of different projects. And I've never followed that. I do research on all kinds of things that strike my fancy, and I recommend that to others as well. That you should kind of follow. Sometimes the tangents get you in interesting places.
I love that. I love like that generalist mentality. I feel like that's where all the like innovations come from.
Yep.
Another question that we've been asking recently is, did you have a favorite failure or even just like a challenge that you had to overcome at some point during your career and some that you felt you actually ended up learning something from, like a valuable lesson, or that led to something else? Do you have any examples like that you could think of?
When I was an ID fellow at Case, we did not have I was interested in doing a master's degree in epidemiology. I'd become interested in doing clinical research, and that was really not available at that time. It is now, but it wasn't part of the curriculum. And so I ended up doing something completely different. I was interested in how antibiotics promoted VRE colonization. So instead of doing a case control study, like everyone else was doing, I developed a mouse model of colonization, and it took us. Then that ultimately led to collecting stool samples from patients and looking at VRE colonization completely in a different way than other people were doing. So that was, I think, a good example of how sometimes things that look like a negative can become a positive ultimately.
Yeah. I've said this on the show before, but I'm sort of obsessed with like hearing people's stories. I don't like to read biographies, but I like to essentially hear biographies, and people always talk about that. They always remember the failures, and then it seems like the people that are more resilient, they make something out of it. It takes them down a different path, or it prevents them from going down a path that their life would have been totally different and maybe not as great had they succeeded in that, what they were initially trying for. So I think it's really interesting to hear from people. But because I don't want to take too much of your time tonight, I would like Carolyn to give us a case from Kashlak Memorial to get us kind of into the main topic.
All right, so we have a great case for you guys tonight. We have a 64-year-old female who's actually currently admitted to your inpatient service for a diabetic foot ulcer and is currently receiving treatment with vancomycin. She does have a history of C. diff that was treated successfully about a month ago, as well as GERD, for which she's on pantoprazole. So while she's in on your service the next day, she's like, "Doc, I got something to tell you. I'm having diarrhea," and she's very, very worried that the C. diff is back. So Dr. Donskey, how would you kind of approach this? How many loose stools do you think this woman would actually need to even warrant C. diff testing in the first place?
So in somebody who has had C. diff in the past and is now on additional systemic antibiotics, the systemic antibiotics will be the number one risk factor for recurrence. So I would agree with the patient that recurrence of C. diff is a real worry. The current guidelines recommend that you should not do C. diff testing unless clinically significant diarrhea is present, and that really is defined as 3 or more unformed stools in 24 hours. One thing that I would definitely do is ask the patient, what do you mean by diarrhea? Because oftentimes patients will have one semi-formed stool and say they have diarrhea. So I'd like her to quantify for me how many stools she's actually having, and are they really unformed? Are they liquid, or what is the characteristics of the stool? And if she definitely is having diarrhea, then the next question really is there any other explanation for it? Because again, the guidelines say that you should test for C. diff if you have unexplained diarrhea. And so if she received a laxative during her hospitalization because she was constipated and how she's having diarrhea, that would be another alternative explanation. If she just was started on pantoprazole, which can cause a little diarrhea, I'd know that, and that's not something that she's been on chronically. So I want to know more about the characteristics of the diarrhea, and she would be a person who I would definitely consider testing.
I think testing is something. Actually, I know testing is something that I did not really understand much. I was just like, okay, I'm in a hospital. I asked somebody what C. diff test do I order, and I would just order it. But when these new guidelines came out, they sort of put a lot more emphasis on the type of testing. So I wanted to ask you about that, and what sort of testing do you advocate for?
So, the current guidelines give you 2 options, and they don't tell you which one to follow. And I think there are just some caveats for what you should do if you use one option or the other. And I think most of us who are practicing medicine, this is a decision made by the lab often. So if your hospital does a nucleic acid amplification test, or PCR, as a standalone test for C. diff, the main thing to be aware of is that it's a very sensitive test, and you may pick up patients who are asymptomatic carriers of C. diff. And so the recommendation really is that if you're using that as a standalone test, it's ideal if you include some method to reduce inappropriate testing of patients who may just be carriers. So again, asking patients, making sure that patients truly have significant diarrhea with 3 or more stools in a day, and they have not been on laxatives recently or have some other obvious reason why they have diarrhea. And on the other hand, the alternative approach is kind of the European approach, especially in England. This approach has been championed, has been using a 2 or 3 step approach where you first do a test for C. diff antigen with an ELISA, and then follow that up with a toxin test. And the toxin test is used really as a distinguisher to help us sort out if patients are likely to have C. diff infection, with the toxin being positive, versus a toxin negative. They may have mild C. diff, or they may be an asymptomatic carrier. That's not a perfect test, however. So you really have to use your clinical judgment in looking at the patient to correlate the clinical findings with the test results.
I wanted to follow up on what you said there. The definition we had kind of made for diarrhea was greater than 3 stools in 24 hours, and loose stools or watery stools. Those are people that they would be appropriate for testing for the nucleic acid amplification test, right? That's sort of the clinical, especially if they have like other findings that would make you think of C. diff, like the high white count and stuff. Okay, so because that's I've worked in various hospitals. They don't ask you necessarily. They use the nucleic acid amplification test at Kashlak, and they if you send them a stool that has too much form to it, they will reject the sample and they won't run the test. So I guess that's their way of sort of, trying to make sure there's some sort of stewardship over this. But the other thing, I don't know if other hospitals have like a built into the electronic health record, but I wonder have you seen better ways to sort of make sure this test gets used properly?
So with either approach to C. diff testing, it is recommended that formed stools would be rejected, because by definition, the unformed stool would be necessary to have diarrhea. The problem there is that is not sufficient. So lots of patients will have unformed stool because they have received laxatives or they may have antibiotic-associated diarrhea, which gives them some loose stool. Right. And because of that, the formed stool helps to reduce inappropriate testing. But if you are doing a PCR-based test for C. diff, it's really recommended that you do more than that, and there are a variety of approaches. One of these has been to use the electronic medical record and to flag stool samples coming into the lab, so that if a patient has been on a laxative or received a laxative in the last 48 hours, that stool sample may automatically be rejected. And in other places, they have made an effort to improve documentation of diarrhea. So if the nursing note does not say they've had 3 or more unformed stools, they may reject that stool sample as well. This again has been most effective when the lab mediates the discontinuation of the stool sample and asks that you call in if the physician has to call to override that. Just with education of doctors and nurses, that approach has been significantly less effective at reducing inappropriate testing.
It's a lot of moving parts. You have to make sure documentation's right on all sides. Like it just seems to rely on a lot that I don't know that necessarily happens consistently.
So just to go back and dig a little bit more into the other tests that you were talking about. So the stool, the C. diff antigen, is that the GDH, where and that sort of says that there's a Clostridium species is present, but it doesn't necessarily tell you if it's making toxin or not. So the second test is to see if there's toxin.
That's correct. The GDH is a quite sensitive test. It's nearly equivalent to PCR in picking up the presence of a C. difficile organism in the GI tract. It, however, is not It's not specific. So yes, if the patient is colonized with a non-toxin producing strain of C. diff, that will also be positive. So a positive GDH with a negative toxin could be somebody who has a non-toxigenic strain of C. diff, or it could be someone who is an asymptomatic carrier. They have a toxin-producing strain of C. diff, but they're not producing enough toxin to result in clinical symptoms. And in a number of recent studies, it's been suggested that those patients who are carrying C. diff but don't have a positive toxin assay, a positive free toxin, will have a low risk for going on to develop complications. And you may do just as well by not treating those patients or just observing them and making a decision clinically. For a few of those patients, you may treat them. For a lot of those patients, we don't treat them at all.
And so our theoretical patient who, let's say that she was successfully treated for a toxin-producing strain of C. diff, how long after completion of treatment can we expect the toxin to remain positive when being tested?
So during treatment of C. diff, as you give vancomycin or other medications to treat C. difficile, the positive test will reduce fairly dramatically. So we've done a study of this at the VA, and after one day, about 15% of PCR tests will convert to negative, and then it's about 30% by the second day, and half of them convert to negative by the third day of treatment. And toxin goes down, similarly. At the end of treatment, 10 to 20% of patients may still have a positive PCR for C. diff, and a lower number may have a positive toxin. After you stop therapy, however, the C. diff treatments that we're currently giving kill C. diff, but they also kill off a lot of the normal microbiota. And so the C. diff may regrow, and about half of patients will have detectable C. diff for a period of weeks after successful treatment. And about a third of them will have a positive toxin assay about 2 weeks after stopping treatment. So again, that's something to be aware of if you are retesting this patient. She may have a positive PCR or a positive EIA for toxin, even if you give her a laxative and that's why she has diarrhea, she may be test false positive.
I wanted to just go just for the nomenclature for the audience, because I was not familiar with this, so this is why I'm pointing this out. So the nucleic acid amplification test, that's the PCR test you're referring to, and that tests for is it TCD B gene?
Yes, it tests for the toxin B gene.
Okay.
C. diff, yep.
Okay. And then the ELISA, the enzyme immunoassay, that's the GDH, and the toxin, both those tests are the ELISA or enzyme immunoassays. Is that correct?
That's correct.
Okay. All right. So I think I have it down now. So we have our two pathways. We can either go with the PCR test or we can go with the GDH and the toxin testing. And clinical judgment always has to weigh in here, it sounds like. And Paul asked, we sort of just went through that repeat testing is sort of, I guess, what Paul was getting at. Repeat testing not recommended, right?
Repeat testing is not recommended. If the test is negative, the likelihood of recovering the next test being positive has been shown to be very low in many studies with whatever test method you use. And if the test is positive, a number of patients will continue shedding C. diff and continue to have a positive toxin assay. So routinely doing repeat testing is not very helpful, because even if your symptoms have resolved, the test can remain positive.
Yeah. Okay. I figured that's been asked for me. Students have asked me about that. Residents have asked me about that. And I thought the answer was no, you shouldn't do repeat testing, but I'm glad to hear you confirm that for people.
Sure.
Yeah.
Carolyn, where are we going to take this next? Do we have another part to the case?
So let's say that we have treated, so we sent the C. diff test for her because this is the first time we're sending it. We did not repeat it. But it turns out she does have C. diff again. So as we kind of progress to treatment, I kind of want to talk about some of the biggest changes So let's assume that this is actually her initial C. diff episode. So how do you actually treat an initial C. diff episodes per the new IDSA guidelines? Essentially, like, why was Flagyl fired as the first line treatment?
Yes, this is the biggest area of biggest new change with the guideline is that metronidazole is no longer recommended. So there's a joke in ID that has been around for a long time, and that is if your mother-in-law got C. diff, you would treat her with metronidazole. But if your mother got C. diff, you would give her vancomycin, and that is in large part because of the pharmacokinetics of the drug. If you look at the two drugs, vancomycin is not absorbed when you give it orally, and it achieves very high concentrations in the colon where the C. diff is. And on the other hand, metronidazole is almost entirely absorbed in the small intestine. So if you have inflammation of your colon and diarrhea to help move the metronidazole into your colon, you get low and inconsistent levels of metronidazole in the colon. So it works, it suppresses C. diff, but a number of studies have shown that it works less quickly. It's less effective, and kind of microbiologic response is slower, and less consistent. So many patients fail. And so it's been, again, used, and in old studies, metronidazole and vancomycin were equivalent. Prior to the 2010 guidelines, the last version of the guidelines, there was a study that showed that in patients with severe C. diff, metronidazole was inferior to vancomycin for response. And so the previous guidelines dropped metronidazole for severe CDI. In the current guidelines, there now is another randomized trial that has shown that metronidazole is inferior to vancomycin also for mild to moderate cases of C. diff. And so they went ahead and eliminated metronidazole from the standard recommendation based on that evidence. Although it's kind of left in there as an aside that, if there's an expense issue because the cost metronidazole is inexpensive, you might consider giving metronidazole as an option. So it's still left in there as an option for mild to moderate only CDI, but the preferred agents are vancomycin and fidaxomicin, both of which are equivalent in efficacy.
Curtis, just a couple years ago, I remember when vancomycin first started to be used a lot more, at least, for some patients in the hospital. I remember discharging patients and having them tell me that vancomycin cost them like $1,000. Is that still the case throughout the country? Is that problem gone now that the guidelines are putting it as a first line and it's such a common illness?
So that problem is less than it used to be. So a lot of hospitals now make vancomycin by taking the IV formulation and making a liquid formulation of vancomycin that you can then take compounded and given to patients that way. And that's what we've been doing at the VA. There now is a less expensive capsule form of vancomycin as well, which is also quite inexpensive. So that problem is not entirely gone, but it appears that it's significantly less than it used to be.
The other question I wanted to ask you, so this, for an initial C. diff episode, or really for any C. diff episode, I think one of the things that tends to confuse people or tends to seem like is the classification system. So can you tell us how would you recommend the audience classifies C. diff infections, because that sort of helps with the treatment as well?
So, and again, the current guidelines really acknowledge that we don't have a great classification scheme, but I think the recommendation of the guideline is reasonable, and that is that patients who have a white count of greater than 15,000 or a creatinine of greater than 1.5, we can classify as having severe CDI, with other patients being considered mild to moderate. Within that classification, however, I would just note that if you can sometimes see a patient who is having 20 stools and has some abdominal discomfort, and you clinically know that patient has severe CDI. So you would add to severe C. diff patients who, in your clinical impression, have severe disease. And then fulminant C. difficile really is when you have an ileus or sepsis It's really for patients who are sick enough to be in the ICU with CDI, and especially the presence of an ileus or evolving ileus would be a marker for a fulminant case of CDI.
Does the IDSA have any recommendations as to when to get surgery involved? Obviously, on the inpatient setting. I think the AGA, if I remember right, does actually, I think, at the severe level. But is there something comparable with the IDSA guidelines?
So the IDSA guidelines recommend getting surgery involved for fulminant CDI. So if the patient has sepsis or an ileus or evolving ileus, those patients would be candidates for a surgery evaluation.
One more thing, and this might seem like a small point, but let's say a patient's baseline creatinine is 2, and now they have C. diff. Are they automatically severe? Is that purposely built into that number? Is it like 1.5 times normal, and that's where they got that from?
They just left that. The previous guidelines had this classification that if you were 1.5 times your baseline creatinine, it would be count as severe, and it was just too confusing because people didn't have a baseline creatinine, or they didn't want to calculate it, and so they just, for simplification purposes, again realizing it's not ideal, said if your creatinine is greater than 1.5, and having an elevated creatinine and renal insufficiency would be one potential marker for somebody who may have more risk for adverse outcomes with C. diff.
Okay, I like that explanation. I can deal with that.
And I would just note that the other, again, the imperfect situation that we have, many times you'll see patients whose white count is greater than 15,000, and you know that it's probably because they have pneumonia or some other condition. But we don't specify that you have a white count of 15,000 and it's just due to C. diff. Just for simplification purposes, we use those two criteria, and it really makes very little difference now. Anyway, could be if you are looking at the current guidelines, vanco and fidaxomicin are recommended as first line for severe or mild to moderate CDI. It just helps you if you are thinking about giving metronidazole as an option, you're going to avoid it in somebody whose white count is above 15.
I know though too, they do recommend though in the fulminant to add the IV metronidazole. In addition, if someone has an ileus or they're in this sort of like shock type picture, how long do you recommend folks stay on that IV flagyl until they clinically improve? For 10 days? Do you treat them for a full course or?
Yeah, so I don't think the guidelines specify that has to stay on for the entire course. So the reason why we recommend metronidazole given IV for patients with fulminant C. diff is really particularly for those patients who have an ileus or are maybe evolving into an ileus. And the concern there is that you may be putting a dose of vancomycin, and it may all be, if their bowels are not working, it may all be sitting in their small intestine and not getting to where it needs to be. And so you're adding an IV agent, which is widely distributed systemically and will hopefully get in across the inflamed colon and provide some additional benefit. So that's the rationale for adding metronidazole. And in practice, what I tend to do is I keep the patients will be on both of those agents. Once they stabilize and they're improved significantly, I would just switch them over to just vancomycin, and I often reduce the dose to the fulminant. The guidelines for fulminant CDI suggest 500 milligrams 4 times a day, which is a lot of vancomycin, and so I tend to back off on the dosing as well once the patients stabilize.
Oh, okay, very interesting. And so with the initial infection, it sounds like most people are going to get vancomycin, the 125 milligrams 4 times a day. And they keep mentioning fidaxomicin. It seems like probably impractical for most patients to go to that as first line just because of cost. Is that mostly being reserved currently, at least in your practice, for like recurrent infections?
Yeah, and I think that's true for a lot of people. It's really, if it weren't for the cost issue, I would probably give fidaxomicin for essentially all of the patients that I treat with C. diff, because it does have the lower risk for recurrence with equal efficacy. to vancomycin. But again, in reality, because of the cost, we tend to reserve it for patients with a recurrence who may be at high risk for subsequent recurrences. I also sometimes use this as a bridge to fecal transplants. So there are some patients, if I'm giving them transplant by oral capsules, I may give fidaxomicin as a bridge to that because I'm not going to clean out their intestinal tract before I do the transplant. And then finally, there is this is not in the current, not recommended in the current guidelines, but there is one kind of observational study where they looked at fidaxomicin tapers for patients with multiple recurrences and suggested that they got pretty good results by doing a variable length vancomycin taper over the course of a month or so after an initial course of therapy. So I sometimes do that as a patient. For patients who have multiple recurrences, I may do a fidaxomicin taper.
I think that was that the Extend trial that Carolyn, you had put one in the show notes here. I think that might have been it.
Yeah, no, it's actually there's another study where they, prior to the Extend trial, where they had done this for patients who had multiple recurrences. So these are patients who are really candidates for fecal transplant, who've had 2 or 3 or 4 episodes of CDI in the past. And they gave those patients a fidaxomicin taper over a course of about a month. It was used typically 2 courses of fidaxomicin. The Extend trial is similar, but it is a different. The Extend trial is looking at patients with initial cases or first recurrences.
Okay. So fidaxomicin normally is like 10 milligrams or 100 milligrams twice a day, right? And then with the taper, at some point they go to just once a day and just keep it on. Is that essentially what they do with it?
Yeah, fidaxomicin is given twice a day, and with the Extend trial, you give the first 5 days with 200 milligrams twice a day for 5 days, and then if the patient has responded, you could then switch them over to one dose every other day to complete the course. So that would be an additional 10 days, 20 days of treatment.
Okay.
I'm curious. I know fidaxomicin is really expensive, but recurrent C. diff seems to be such a huge issue. Is there anything to suggest that there's actually a cost benefit with fidaxomicin if you're saying that it actually decreases long-term reoccurrence rates?
Yeah, so there's a lot of debate in the literature. So if you do a search on cost effectiveness and fidaxomicin, I actually just did this today. You can find systematic reviews and cost analyses that suggest there's a benefit of fidaxomicin, and you can find others that suggest that it does reduce recurrences, but it's not cost effective. So there's still a lot of debate in the literature regarding, is it really cost effective? The evidence is not entirely clear. In my opinion, because there's this debate, the easiest thing for clinicians would be an algorithm of some sort that says if my patient meets these 3 out of these 4 criteria, fidaxomicin may provide a better option. And we really haven't come up with that as a way to guide clinicians. So it's still, it's still a matter of if your hospital, supports use of fidaxomicin for these patients, or if in your personal practice it hasn't become something that we have a clear benefit for this subgroup of patients.
I wanted to ask about how you recommend the vancomycin taper is done. To me, it seems like people do it a little differently based on, like, once someone's in their second or third recurrence, it seems like kind of like people just do whatever they think might work. Is that true? Or am I just misunderstanding the practice? Is it still that much of like with steroid tapers, for example, for COPD, everyone does things a little bit differently?
Yeah, I think that's somewhat true. In our facility, we have vancomycin taper as part of our order. We have an order set for C. diff, and so there's kind of a standard taper that we use in our facility. But for hospitals that do not have that, the current guidelines recommend a wide range. You can taper for 3 or 4 months. There's really no one has done a trial to really prove that vancomycin tapers are superior to fidaxomicin or other regimens for C. diff. The rationale for tapering vancomycin is that it may give, as you taper the vancomycin dose down to a low dose, the normal microbiota of the colon may be able to start to recover and fight off C. diff trying to regrow. And also, you just are simply giving more time for the C. diff to clear out of the colon. Some of those spores that are still hanging around at the end of a 10-day course may be gone by the time you get out to a longer treatment course. The only study that really looked at different durations of treatment did not suggest that a longer duration did not seem to do any better than a shorter duration in terms of reducing risk. But again, it wasn't a controlled trial.
You mentioned frozen capsules for the fecal microbiota transplant. Can you talk a little bit about, let's say, we'll take recurrence first, and for recurrent C. diff, are you going to the capsules as your primary practice, or are you having it administered by colonoscopy? I know there was an article recently sort of comparing the two.
Yeah, so we started out, and I think in Cleveland, we were probably the first VA in the country to be routinely doing fecal transplants. We started out doing these by colonoscopy. And then we transitioned relatively quickly to first frozen capsules, but now we actually do freeze-dried capsules. And we work together with one of the other hospitals in town as kind of a little bit of a joint program. And so we have now done, I think, as between the two hospitals, maybe 100 or more by freeze-dried capsules versus 40 or 50 by colonoscopy. So most of our transplants now are done by capsules in the outpatient clinic. We just see patients and consent them and give them capsules that way, and that's become a standard practice for us. And I do this. It depends on the patient. Patients who have a second recurrence, usually we would like them to have a fidaxomicin or a vancomycin taper, and if they fail one of those, then we might move on to fecal transplant as our approach. But again, we're doing this pretty routinely now.
Can you talk about what the prep? Let's say we have someone on a fidaxomicin taper, they're still having diarrhea. What would be the process of giving them these freeze-dried capsules that you're talking about, and how many capsules do they get? Just so people kind of know if they're telling a patient that you might need this, how would you counsel the patient, like what's going to happen?
Yeah, and again, the freeze-dried capsules it would be very similar to, probably more commonly people are using frozen capsules. The process would be very similar. For colonoscopy, we typically recommend a full colonoscopy prep where you're cleaning out the colon, getting rid of all of the vancomycin and all of the that may be there that might kill off a transplant, and trying to eliminate any residual C. diff from the colon and other bacteria that may compete. For capsules, there are some studies where they've done a prior preparation, but we do not do a prior prep for patients. So patients really, we usually stop to give their last dose of fidaxomicin or vancomycin 2 days before the transplant. Then they come into the clinic, and we give them capsules, and I have them take 30 capsules total. Although there is a recent study where with freeze-dried capsules, they've gotten it down to as few as 2 to 4 capsules.
Oh, wow.
Yep. And that's just by concentrating and using special methods to really get a very high concentration of bacteria. And, I sometimes let patients take some of the capsules home. They can show me that they can swallow, half of them, and then tell them they can take the rest of them after they get home.
I'm sure people...
I'm sorry, did you say 30?
That's so many. Like over what period of time do they need to take 30 pills? Like in 1 day, in 2 days, in a week?
Yeah, so we would typically give it. So we have a number of elderly people who gobble down 30 of them in a half an hour in clinic and have no issues with that.
Oh, I hope they're not chewing them.
No. But again, with freeze drying, they're pretty odorless actually, and people do fine. I tell them they can take it over 1 day or over a course of 2 days, and I give them that option, but whatever they're comfortable with.
I honestly, before you said that, I was like just picturing them just having like a stack of pills and just like 30 sips of water in a row, and they're just kind of like Or wow, that is well. Let's all cross our fingers that the 2 to 4 capsule protocol takes off and really holds up for future studies.
No kidding. Their C. diff's better, but they're in heart failure exacerbation now from all the sips of water.
Yeah.
I don't know if I could convince a patient to do anything that requires 30 pills.
Yeah, when you've had multiple recurrences of C. diff, and the other option is a colonoscopy. It's actually not bad there.
Yeah, it's a fair point.
They're just happy they don't smell bad. I see them. I can just mention one other thing about fecal transplants. So again, my impression about fecal transplants is that this is likely to progress so that at some point in the future, unless we run into issues, this will be something that everyone, internists will be able to administer these in their practice. You won't even really need an ID person to do this. And then the other place where this is kind of experimental as well and not recommended in the current guidelines, but for patients who have fulminant C. diff, we occasionally see patients where there are case series where some patients have had great responses to fecal transplant. So we recently had a patient, an HIV positive patient who had fulminant C. diff, whose white count, I think it started out at 25,000 and it was gradually rising up to almost 50,000. And he was due to go to the operating room the following day. And we did a fecal transplant, in this case through an NG tube. And he responded miraculously, and he felt a lot better by the next morning, and his white count came down, and we saved his colon.
Wow,
that's incredible.
Was he off antibiotics when you did that? Like, did you just have to stop them? It sounds like they weren't working anyway. But
yeah, so the way we did the transplant, that's our concern. If you have a patient who's on vancomycin, that will kill off and metronidazole. Those antibiotics will kill off the normal microbiome, and so that is that's why they cause recurrences. And so we switched this patient a day earlier when we thought that we might be doing the transplant to fidaxomicin, and then when we came in, we left him on the fidaxomicin for a couple of days. Again, fidaxomicin is very narrow. This is the advantage. It's a narrow spectrum. It only kills off the Clostridia, essentially. So it leaves Bacteroides and a majority of the anaerobes there. And so we were prepared to give him a second transplant, but again, he responded so well to one transplant that we did not do additional transplants.
Very cool case. There was a letter to the editor in the New England Journal, I think it was June of this year, and I'll put it in the show notes, and they basically... They said that they did this. I think it was a small series, like 20 patients, like nine got for initial C. diff infection, they got an FMT, and then for the other 11 just got the standard treatment. And they, at least in that very small series, they said it looks favorable, and I guess there's a bigger trial ongoing. Is that something that you've done too? Like, have you tried to treat the primary infection with a fecal transplant?
Yeah, we have not done primary episodes, but again, this again is part of the kind of rapidly moving picture with fecal transplants, and that there was a recent publication as well that where they gave patients fecal transplants. In that series, there appeared to be no benefit in giving fecal transplants to patients who had mild to moderate C. diff, but for patients who had severe C. diff, giving a fecal transplant actually was associated with a reduction in mortality over standard treatment.
Wow.
So you're saying that the next round of IDSA C. diff guidelines could look completely different, and maybe Vanco will be gone by then?
Well, no, I think vancomycin, it's going to be harder to get rid of than metronidazole, I think.
That's fair.
Yeah, it's got a weaker hold, or it's got a stronger hold on things. Well, yeah. we have a bunch of, well, Carolyn, I'll let you run things here. I know we have social media questions we wanted to get to. Is there anything else you wanted to ask before we?
I did want to ask one thing, since you're an expert definitely in infection control, is I always see families and patient members' rooms with C. diff who aren't wearing gowns.
Yeah,
should they be wearing gowns? Should they be worried about getting C. diff? How do you counsel these patients and their families?
Yeah, I often get this question, not so much for visitors, but people going home from the hospital are often very concerned that their grandchildren or someone in their family will get C. diff. What I tell people is that unless your family member is taking antibiotics, which are the number one risk factor for C. diff, or are immunocompromised for some reason, the risk to them is very low. And again, we as healthcare workers are around C. diff all the time, and we don't usually worry about getting C. diff. It's just if we take an antibiotic, we'll be at risk too. I actually we published a case series of healthcare workers who got C. diff after taking antibiotics. Same thing for people at home. That's the main risk factor. We do recommend that if you come to the hospital to visit, that you would put on the gown and gloves, but I don't think we enforce that very well. I think that's the main issue.
And have the guidelines softened on soap and water hand washing? Like, I was a little bit surprised to see that alcohol, it was like, maybe it's kind of okay, but just go ahead and wash your hands. But like, it just seems like they sort of softened a little bit in terms of what you can do.
I noticed that too.
Yeah. So, because there isn't a randomized trial that shows that hand washing is better than using alcohol, the guidelines are very conservative. They don't want to recommend this, but it really doesn't make any sense to use alcohol after coming out of a C. diff room, after you take off your gloves, because there is a small risk for contamination. Even with the removal of gloves, you can contaminate your hands when you're taking off your protective equipment. So I recommend soap and water hand washing anytime you're coming out of a C. diff room after removing your PPE. The current guidelines, however, they're the same. I think they're really the same as they were last time. They say if you have an outbreak, then you might consider enforcing, hand washing with soap and water. But otherwise, it's okay to use alcohol. It is true that the gloves will keep most of the spores off your hands.
Gotcha. Go wash your hands, is what you're saying.
Yeah, and I would just recommend. One other thing that we recommend, for patients with C. diff, we tell them to bleach their bathroom at home, but we recommend patient hand washing as well. So the patients and bathing for that matter as well. Right. Patients who have C. diff, especially in the acute phase, will be covered from head to toe in C. diff, and as that infection resolves and their diarrhea starts to go away, we want them to change their clothes, shower as best they can, and regularly wash their hands if they're leaving their room, because the hands tend to be contaminated with spores. So we strongly recommend that.
Great. So we have some great questions too from our social media. So the first question that our listeners have for you is there any evidence that loperamide will actually cause toxic megacolon when used in C. diff diarrhea?
So there are some case reports of toxic megacolon in patients who have with C. diff or patients with ulcerative colitis that loperamide may has been associated with development of toxic megacolon. So in the current guidelines, what they really recommend is that if someone has an acute diarrheal syndrome or acute diagnosis of C. diff, that you not give them loperamide due to that concern. However, for patients who've been on treatment for several days who are showing signs of improvement, I actually don't mind giving them an antimotility agent at some point after day 5 to 7 of treatment if they're still having significant diarrhea. They're improving, but not improving fast enough. And then we have a lot of patients who have they progress from C. diff to kind of an irritable bowel syndrome that takes a long time for them to normalize. So I occasionally will give loperamide to those patients, but I do it while they're on kind of undercover of the C. diff treatment.
That's awesome. I can't actually wait to try that out with some of my patients. I'm sure they're gonna love it. By like day 5, they gotta just be so tired of having that much diarrhea. Another question that we have from our listeners out there is that, so you have a patient with C. diff and you aren't really sure what the trigger is. Would you think twice about prescribing them clindamycin? And I think they're just trying to sort of ask, what sort of antibiotics tend to be associated with C. diff? What are you trying to avoid if you can?
So, I try to avoid clindamycin no matter what. It's a very strong promoter of C. difficile. So if I have an alternative, I almost never give clindamycin at all to patients. I always look for an alternative. So if someone has received, if someone has received an antibiotic and got C. diff, it's not so much that I try to avoid the antibiotic that they previously received, but if I have a choice, if I'm looking at a choice of different antibiotics that I can give, I try to choose the one that, at least in theory, might be less likely to promote C. diff. And so, for example, there are a number of recent studies and case control studies that have suggested that doxycycline has a relatively low risk for C. diff. It doesn't cause much adverse impact on the normal intestinal flora, and it actually has some inhibitory activity against C. diff. So if I have a choice of giving doxycycline instead of moxifloxacin, for example, to a patient, I will do that. So, and there are other agents, that may also have some benefit. So Bactrim is relatively narrow in spectrum. It doesn't kill C. diff, but it's relatively narrow in spectrum in comparison to some other agents. If in your facility you're trying to reduce the risk of C. diff, we always say that penicillins, piperacillin tazobactam, for example, would be preferred over cephalosporins because as a generalization, cephalosporins have no activity against C. difficile, whereas the piperacillin tazobactam and penicillins are active against C. diff, and if they're excreted in bile, you can actually get some inhibitory activity while you're taking those agents, and maybe less likely to get C. diff.
Oh, I would have. That's interesting. I would have thought it was the other way around. I would have thought that cephalosporins were narrower than pip-tazo. So that's good to know.
Yeah, and within the cephalosporins are a broad class of antibiotics. There are some of them that have more anaerobic activity, and some that are excreted primarily in through the kidneys, and that may have less activity. So ceftriaxone would be a strong promoter of C. diff. Whereas, cefazolin or even cefepime might at least in theory, be less likely to promote C. diff.
Do you have like a C. diff hierarchy handout or something that you give for teaching purposes? That would be great. We could put it in our notes. I know I've seen one on like a pharmacy website before, but I could send it to you to fact check if you'd be down with that.
Sure. Trying to think. So there is a review article. I think I'm the second author on a review article from several years ago where the focus was antibiotics and C. diff infection, where we do talk about agents that are more or less likely to promote C. diff. It really focuses primarily on agents that have activity against C. diff versus less activity. Okay. Yeah, I'm not sure if there's anything else that's really good for that.
Yeah, I'll be sure we'll link it in our notes.
Yeah.
That way we can all take a look. And on that note too, so probiotics, what do you think about them? Do you ever use them in your practice? Do you recommend any brands? Is there even any evidence for them?
So there is some evidence for probiotics as a prevention for antibiotic-associated diarrhea, and some evidence, including in kind of meta-analyses, that it may be good for primary prevention or even secondary prevention of C. diff recurrence. What the guidelines say is that although there is some evidence, it's just not that. The evidence is it's conflicting, and it's not that convincing that probiotics are likely to be that beneficial. So I personally do not. I don't mind if patients take probiotics or if they eat yogurt, but I don't personally prescribe probiotics for C. difficile. I think ultimately we need to develop. Obviously the fecal transplants work. Most of the probiotics that are kind of lactobacillus or bifidobacteria based don't seem to be nearly as effective. And so I think what we need to do is generate more effective probiotics.
On a prior episode, the great Dr. Paul Sachs, he suggested, because we were asking him similar questions about C. diff with the antibiotics, and he was suggesting maybe in the future, after you complete a course of antibiotics, you might take fecal, like the capsules, and you might repopulate the flora that way with healthy bacteria, and that would be sort of your prevention once you completed the course. I thought that was a novel idea, and if you're saying that the 2 to 4 pills might be enough to give a fecal transplant, then that might be like you take 1 pill after you complete your course of antibiotics or something like that. I just thought it was interesting.
Yeah, no, I agree. And there's one approach that's been discussed but really never studied is maybe we should all bank some stool samples, and we could have our own replace our own flora after we take antibiotics, as opposed to getting some stranger's bacteria.
I was just thinking that my kids would really love this show that we've been just talking about fecal matter the whole time.
Sure.
Someone's going to listen to this and then start a startup just on that topic.
Yeah. Well, there is one in Boston that we had talked about before. Is that I can't remember the name of it, but they don't need a free plug anyway, right, Paul?
No.
But there is a startup, but it was I believe it was founded because their friend had C. diff and they wanted to help their friend, so supposedly that's the lore behind why they started it.
Yeah, there is a group in if it's the same group you're thinking of, they would Open Biome, put in a plug. Mm-hmm. They bank stool samples. They have a group of very smart MIT students, I think, who provide stool samples, and they ship them around the country. And I think most people who are doing fecal transplants now probably use that type of arrangement. That it's easier. It just takes a lot of the work out of it, rather than having your own donors.
Yeah,
you get samples that way.
Right. Yeah. We on a previous episode we had talked about some of the ins and outs of that, and it seems like the donor screening is pretty rigorous to make sure that people aren't going to get sicker from taking these transplants. So I'm sure that's something that patients ask you about a lot.
Yes, and we follow standard screening for blood tests and stool samples. Probably not as rigorous as they do at the commercial or at the Open Biome group.
One other question I wanted to ask you, and then I'll if Paul and Carolyn have a final question, I think we need to let you go. The patient that we initially had, say this is a woman, she has known history of C. diff, she's coming in the hospital, she's going to need broad spectrum antibiotics. Is there any utility in like putting them on oral vancomycin like at a lower dose than the treatment dose to try to like prevent C. diff from taking hold?
So that is an active area of, first of all, debate, but also of study. So I know, and there is some data, a couple of publications now, and more are coming. That the data is a little bit mixed. One of the studies suggested that if you had an initial episode, it wasn't really beneficial. But if you'd already had a recurrence, it might be beneficial to put you back on kind of suppressive vancomycin. And again, more studies are coming. I know in bone marrow transplant unit, for example, they gave a lot of the patients oral vancomycin suppression. The other part of your question, though, was actually very interesting. So vancomycin we give when we give 125 milligrams 4 times a day achieves very high concentrations that are so high, in fact, that vancomycin, which is a gram-positive drug, kills Bacteroides because the concentrations are so high. So this is it's a very important point that in theory we could reduce the dose of vancomycin so that it may be more narrow in spectrum and preserve Bacteroides and might be less damaging to the microbiome. And if you were going to give it as a suppressive therapy, that's what you would want to do. You'd like to try to make it as harmless as you possibly can to reduce adverse effects.
Mm. Paul or Carolyn?
I don't have any final questions, but I do have a C. diff joke.
Okay, go for it.
I'm not getting in the way
Let's see.
of that.
So everyone I've told it to today hasn't been sold on it, but I'm hoping that after we had this discussion that you guys will appreciate it. So
Yep, time to take it national. Great.
yeah, so we'll see if you guys enjoy it. But a C. diff, he is going to his primary care doctor. for his yearly routine visit, as all good C. diff spores do. So his primary care doctor is like, hey, look, I noticed that you're kind of gaining weight, and I'm really worried about kind of your unhealthy weight, and I think we really need to make some lifestyle changes. So I want you to work on your diet and get more exercise. C. diff says, exercise? I don't like that. I'm not going to exercise. Doctor says, well, it's really important. It's like part of your health and trying to keep you healthy. C. diff says, I'm not going to do that because I'm anaerobic.
Oof. Yeah, I feel like Stuart's with us here in spirit.
Yeah. Listen, Stuart would be doing cartwheels down the hall. You just don't have the right audience here. So.
I tried.
I bet you a small subset of our audience will love that joke. So thank you.
I think probably a huge subset, actually.
Yeah, that was good.
Thank you.
Curtis loved it. Well,
you don't hear many C. diff jokes. You hear a lot of stool jokes, but not just pure C. diff. So,
all right.
Well, thank you for being a spore-tacular guest.
Gosh. Oof. Oh boy, I think we better get take-home points. This is getting a little. Yeah, Curtis, did you have some take-home points that you'd like to share with the audience?
Yeah, I mean, I really just one main point, and that is that we see patients who have C. diff infection, but I think all of us who work in the hospital have to appreciate that C. diff colonization is very common. There are more patients out there who are asymptomatically carrying toxin-producing strains of C. diff than there are who develop disease, and that really complicates everything that we do for infection control and also for diagnostic testing. Because if we give our patients a laxative or if they have diarrhea for some other reason, we could diagnose them with C. diff and end up giving them some antibiotics that they don't really need. So that's, I think, just keeping that in mind as you think about diagnosing and treating C. diff, that there's a lot of C. diff out there that is not causing disease.
Well, I think you've armed us with the knowledge to deal with that now, and I think everyone knows a lot more about the testing and the treatment of C. diff, and hopefully we'll see some more responsible practice in this area. And I'm excited some of the things that you talked about here to kind of follow this, because it sounds like, as Carolyn pointed out, the next guidelines are probably going to have some differences again from the previous ones.
I agree. It's rapidly evolving.
Thank you so much.
All right. Yeah, thank you. I appreciate the opportunity to join the Curbsiders.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. You can get show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food. We'd love to hear your feedback, so send an email to us at thecurbsiders@gmail.com or just reach out on Facebook, Instagram, and on Twitter at The Curbsiders. Until next time, I've been Dr. Matthew Frank Watto.
I'm Carolyn Chan.
And I remain Dr. Paul Nelson Williams, and goodbye.
And thank you to Carolyn Chan for producing and helping to write this episode, as well as to all of our team of Curbsiders, especially our social media team, Hannah R. Abrams on Twitter, Beth Garbatelli is on Instagram, and Chris, the Chew Man Chew, is on Facebook. Thank you and good night.